juice out of the stomach. You might have given too much of a diuretic. You caused the problem, okay? Which happens all the time. We cause, especially respiratory-wise, because when we're setting up the ventilator, we know the tidal volume, but we guess the rate. So if you guess it wrong, you just fix it. But if it's an iatrogenic problem, you caused it. You can cause metabolic ones. You caused too much. You get the NG too much suction. You gave too much Lasix and the patient's peeing away. Those are some examples, okay? So I'm going to ask you about iatrogenic. I'm going to expect you to know both respiratory and metabolically how you could make boo-boos, because we make boo-boos all the time. I'm just looking for my glasses. I hate when I don't have them on because it's hurting my eyes. Acidosis, what causes respiratory alkalosis? So understand.
And those are in the boxes in the chapters.
If I said to you to describe in words what causes respiratory acidosis, what would you tell me? Let's put it this way. If you can do this.
Hyperventilation.
Yeah, hyperventilation.
Basically,
pH.
be able to do this. If I said to you respiratory acidosis, it says down pH and up CO2.
Yep.
Well, now you can start talking. Hypoventilation. Right.
Yeah, I have to write it out. Me too.
Be able to.
So we can do that when it's asking what's causing it. Like we can write out what it would look like.
Absolutely.
And that's basically telling us.
I highly suggest on the exam when you get it to write down your pH, CO2, O2. Write it all down so that it's there. And I highly, highly suggest that you don't try to do blood gases in your head. If you notice, I've been doing them for 35 years. When someone asks me one, I don't try to do it in my head. I write it down. And they're simple. Don't second guess yourself. And I'm going to tell many of you, once you're done, pass it in, because then you start changing your answers. Answer changers. And you're going to convince yourself, oh, that was a respiratory acidosis. Go through it. If you got the answer, cross it out and do not go back to it. Because I'm not going to on this test. If you had it right, give you credit. You got to learn. We're in the big girl chair now. We're in the big leagues.
Can we bring
Okay.
you to the boards? No.
What?
Can we bring you to the boards?
You can bring me to the board. Then I'm going to start asking you about compensation and partial compensation. Now, not only is it going to ask you to read it, but what they're going to say to you, and the way they know that if I give you this, they're going to tell me that's partially compensated respiratory acidosis. But what you need to be able to do is, without numbers, say with partially compensated respiratory acidosis, you have an increase in CO2 and an increase in bicarb. So be able to say it out. Now, if you get to a question that it's giving you words, put numbers in there so it makes sense to you. Okay? You see what I'm trying to say? If they're saying to you, you got a partially compensated respiratory acidosis, what is that? Well, next to the things that they give you, write it out. So if I don't give you numbers and I give you words, make them numbers that you understand. Does that make sense?
Yeah.
Okay. So make it so it understands. Okay?
Partially compensated is all of them.
I really, 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 really do kill you on knowing the difference what's causing the event and what's compensating it. So make sure you got that.
Can you give an example of that? I know you did yesterday, but
Like what?
so you're talking about compensation and
Causes.
Okay.
Yeah,
So causes would be, let's take respiratory acidosis.
Right.
You got a COPDer who now's got a pneumonia, so he hypoventilates.
Yes.
CO2 goes up, okay? The event is the increase in CO2, the decrease in pH. The compensation would be that if we can't fix it, the bicarb is going to correct. But at first, the buffers are going to try to buffer those hydrogen ions. And what they can't buffer, then compensation will take place with. So your buffering system is first. But if that change is so abrupt and it can't, and it doesn't fix itself right away, that's why with acute respiratory acidosis, you don't see the bicarb change, like your overdose. Once we give them the Narcan and reverse it, the patient goes right back to normal. Okay?
So basically, like in respiratory acidosis, like we were just talking about, the cause would be hypoventilation.
Yep.
And then you'd say what's being compensated, then the bicarb would compensate for it.
Yep.
But that's after it tries to buffer.
Yep.
Okay.
Good.
So
Now,
it's just the explanation behind it.
Yep.
Okay. It's
Like
not,
words wise,
Yep.
right?
and they're going to give you all of the following could be causes of respiratory acidosis except. All the causes could be causes of respiratory alkalosis except. Now, you know anything that causes hypoventilation, which is the majority of things. Respiratory alkalosis is, number one is hypoxemia, fear, pain, anxiety, you know, all of those kind of things.
so the AARC guidelines.
ARC guidelines is a biggie there, okay? Yep, you gotta know those. Then I give you some basic, I give you about 5, just pure basic, you gotta interpret them, okay? Then I ask you how to correct them, okay? I do ask you how you would correct each one of them.
I don't think I know how to do that.
Well, honey?
I don't think I know how to do that.
Okay, so now we'll work on that.
Yeah.
So for respiratory, so you know the ones that we did, the big ones? There are probably 10 like those that take half the page.
Oh,
Okay.
Those are tough.
So remember, you fix ventilation first. So if you look at the problem and the ventilation is pretty close to being normal, but it's off like a little, but your PO2 is terrible, you got to fix that PO2. Okay? But you got to fix ventilation first.
And that would be the
Rate
rate and
the tidal
volume.
And on the exam, they never give you both, unless it's purely obvious.
Okay.
Now, if they give you the weight, then calculate out the tidal volume.
Mm-hmm.
If the tidal volume is off, way off, then you're going to do it. If it's on the low side, then you got to fix it. Someone has, if I said to you, you got someone who's got a tidal volume of 200, you know right away that's too
Yeah.
small. Usually it's too big. Most of the time it's the rate.
So are we doing the 3 and 8?
5 and 8.
5. Oh, sorry. 5
5 and 8. 5 and 8 is what we'll go with.
Okay.
Okay. Now, if it's the O2,
Mhm.
you're going to look and see where's the FiO2.
Mhm.
If the FiO2 is around 50 to 60, you add PEEP. Okay? If there's no PEEP, then your answer is add PEEP. You know, there should be PEEP. If they forgot PEEP, then you're adding PEEP.
Okay.
Once you get to 60, you're going to give your PEEP till their blood pressure drops, and then you're going to go up in the FiO2. Now, on this test, they're basically not going to look at that part. They're just going to look to see, do you know FiO2 versus PEEP?
Okay.
Okay? And the same thing with respiratory rate. Now, on some of them, if it's perfectly fine, don't be afraid to tell me to maintain current settings. Okay? Because that's what we're going to look at. Remember, what this test is trying to do is to see if you know what to do with your blood gases. And you're going to have a physician that says, I want to take the patient, you know, decrease this. And you're going to say, we're going to do absolutely nothing because this patient is fine.
Mommy,
Or you're going to have a patient that's weaning, that their CO2 is starting to go back up. And you want to go and fix that, you know. So I'm watching to see when you've got a ventilator, can you do that? Now, your SILS book, all your practice questions, do it. And we did a bunch of them.
Okay.
If I gave you, like on the test, the practice one, you've got a blood gas and a co-oximeter that aren't matching
Mhm.
on their saturations. Neither one, you can't decide, well, I like this one better. You have to recalibrate. So there are probably 10 questions on your machine's not working correctly. What do you want to do?
Okay.
Okay?
Yep.
So I get you on, there's pre-analytical errors. I'm going to give you, you know, if I give you a PO2 is 225 on 28%, you better well tell me that that's physiologically impossible. Everybody better know that venous blood gas on there, or I'll cry. Ooh. You know, we've gone over that enough. So they give you quite a bit. You know, if I give you a blood gas and you see that I'm giving you the sodium, the chloride, and the bicarb, you probably have got a metabolic and they're looking to see, do you know the anion gap? And the reason they're doing the anion gap is so that you know whether it is because of acids or bases, which way did it go? Okay, I'm not going to ask you normals on this test because I'm going to expect you to know them. I'm not going to ask you what a normal pH is or what a normal BE is or what a normal anion gap is. I'm going to give you, here's an anion, figure out this anion gap and tell me what you're worried about here, you know, okay? So that's what they're going to do for you. I do ask a little bit about pulse oximetry on there because we've been looking at it. You all should know that it's non-invasive, that it's much nicer to use than invasive procedures. You know, that you do want to know the things that can mess up a pulse oximeter, you know, fingernail polish, it's not on correctly, all that
Old
good stuff.
fingers.
Old fingers, old probes, all that good stuff. Do know your sites for your blood gases. Do know your Allen's test. Okay, do be able to describe it. And I will tell you that it's going to tell you you release the ulnar artery, you release the radial artery. Again, make sure you're knowing which artery that you're releasing, so understand the process. Know why we pick a radial, even though they're going to tell you it's less painful. It is less painful, so don't be surprised by that. That it is pain, but it's less painful of them all.
Know the difference between true and modified Allen test?
Yes,
Okay.
and the difference was 3 minutes. Know when you would do a blood gas. Why would you even choose to do a blood gas? What would you do?
I know a lot of the board questions are like that too, where they automatically you choose a blood gas. So what do you mean by that? Like, what do you mean when to do a blood gas? And
So
just looking at the patient, you mean, like, and,
Right.
and figuring out the symptoms of the patient.
right.
And that-
So if somebody was cardiac arrest, we would draw a blood
Okay.
gas because we want to see like where their pH is. So say I made changes in the ventilator, I want to see where the patient is. If all of a sudden, you know, I have a patient on the floor and they're really short of breath and the SAT has dropped down and I can't figure out why, I might want to draw a blood gas. I might want to draw that.
Isn't a lot of the reason that, don't you normally just do a blood gas anyway because you know the patient is going to be.
It's the truest value. Remember, when you do non-invasive, you're not always getting the right results. You know, that's one of the problems with oximetry. You might not get a true reading.
Mhm.
When I want something exact, I want to do a blood gas because it's going to tell me my acid base, how they're ventilating, how they're oxygenating. It's going to tell me all that information. So when I need it, it's quick, it's easy, but it's invasive.
I guess the confusing thing that I have is when not to do a blood gas, because I feel like in most circumstances when we're in,
I would just do it
we
on
would
it.
just do a blood gas anyway.
The only time you wouldn't do a blood gas is A, if the patient refused.
Yeah.
B, if the risk outweighed the benefit. So say you had a patient that was on tons and tons and tons of heparin, and their
Mhm.
clotting time was awful, and
Mhm.
you would probably have to hold that blood gas for a good half hour,
Mm.
then you might say to the physician, do you really, really, really need this blood gas? But 9 times out of 10, we do the blood gases because what they give us is invaluable. It's so important what that blood gas gives me that it takes the guessing away. You know, when I use the pulse oximetry, I'm like, yeah, it's 90 or 92, but that's a variation. You know what I mean? I mean, I've many a times had patients that are very dyspneic that have saturation of 97, and I hear, well, their SAT's good, but they're not. So let's not look at that number. Let's draw a blood gas and see what really is going on. Okay? So the blood gas tells you really what's going on. So when you wouldn't do one is only very rarely when the patient refuses or when the risks really outweigh the benefits. You know, that would be the only time. You know, and if you were going to do a lot of them, that's when you would suggest an A-line. Like, you know what? Hey, this patient's going to be getting a lot of blood gases. Let's put in an A-line. And that's what they do prophylactically. If you're going in for any kind of abdominal or cardiac surgery, they're going to put an A-line in before you even go to the OR.
Mhm.
you know, because instead of sticking you 900 times and getting that wrist to look the way it is, let's do the A-line, where you're gonna have one shot deal, and we can draw as much as we want, okay? So we wanna do that. Do know all the complications that you can get from a blood gas. We kind of talked about them. We talked about how you can get a spasm, how you can get an embolism, how you can get infection. You can get a hematoma, you can hemorrhage, you can bleed to death. Remember, we used the antiseptic so that we didn't give them infections right into the bloodstream and get them septic. All those big things, you know. And know when you don't want to do one, like we said, when there's scarring, when there's edema, when there's when they fail the Allen's test, the modified Allen's test. So it's kind of common sense. If you look at that site and you go, oh, I wouldn't want anybody to draw from there. So you want to make sure you do that.
And also, if they have other things on that arm, is that true?
Absolutely. If they've got a shunt for a DVT, you don't want to go and draw a blood gas from that line. So always look at the board and or above the patient's head and say, can I draw a blood gas? Because it's going to tell you yes, no, maybe so. And a big one is any patient that's in dialysis, that arm that has the shunt in it, we're not going to draw anything from. Hello? 2 times, go get somebody else. But you're going to see therapists that have egos and they'll stay in there and it's like, oh, and then they the ones that make it so the next time you got to go do a blood gas, the poor patient is horrified. But it's just like anybody else. You know, when someone goes to draw your blood, you got ones that get it right away, you get ones that dig, or try 9,000 times. Same thing with an IV. So it's common sense. I personally will only go in direct. If I don't get it, I come out. I'll try a second time. If I can't get it, it's just not my day to hit blood gases, and I get somebody else to do it, you know. So use your common sense. You're gonna, you know, sometimes I watch therapists to hold it and I say, okay, come out, I'll try. Again, when you're drawing that blood gas, you know, always look at the site, make sure you got an order, check their heparin, or check their coagulation. Drugs, check their coagulation, their INRs, their platelet counts. Check to make sure they've got a good circulation in the ulnar artery. Make sure there's no air bubble when you run it. You're going to get an air bubble no matter what because of the needle. Make sure if there's heparin in there that you get the heparin out. Make sure you get the air bubble out because you want to know what will happen if you leave them in there. Know what to do if you are doing a blood gas and you only get a small amount of it out. Remember, you could be going through. If you can't get it, you can, God bless you, pull back a little bit and try. You could have gone through the artery. If you try and you can't, then you can try another blood gas. You could try running the sample and seeing if you got enough, but you might get those question marks and go from there. Know your pre-analytical blood gas errors and your analytical errors that you're going to run when you do a blood gas. Again, know that if it's going to sit, you should kind of cool it down. What if I said to you had a blood gas that's been sitting for 100 minutes?
Throw it out.
Throw it out, yeah. After an hour, that blood gas is probably not accurate. You don't want to do that.
Does Venus have to be on ice, or do they both have to be on ice?
Venus doesn't have to be, none of them really have to be on ice unless, because you're going to, the assumption is you're going to run them right away. If you don't run them right away, then you want them to be on ice, is what you want to do. So once they're on, once you draw them, hopefully you know that your blood gas machine is working properly. But if you go down there and it's not working properly and you know it's going to take you a while, if say you have a needle that has the heparin already in it, or you've got to draw the heparin out in the vial and you leave the heparin in there, know what's going to happen to your blood gas. So if you leave heparin in the syringe, does anybody remember what happens? It doesn't anticoagulate because it's got more, but your blood gas results will be off. So your pH is going to be up and your CO2 is going to be down if you leave too much heparin in there. And know what happens when you leave an air bubble in there to the blood gases. Remember, the oxygen can go either way. The CO2 is going to go down because it's going to go into the air bubble. Okay? So know that. I am going to give you some blood gases where there's errors. So I'm expecting you to know that the O2 and the CO2 on room air cannot add up to more than 140. Know your venous blood gas, that's going to be there.
You said the CO2 plus the O2?
Yep, can only be 140.
Okay.
On room air.
On
But
room
then
air.
if there is FiO2, then you have to do the PaO2 equation.
Absolutely.
Okay.
Absolutely. And again, make sure when you're looking at the blood gas that the numbers correlate with what you're expecting from the patient. You know, if you had a patient that's coding in the emergency room and you see a respiratory alkalosis, something's wrong. You know, you're expecting respiratory acidosis because your patient's hypoventilating. So if that's not making sense, there's something wrong with your blood gas, okay? Now, when you do pulse oximetry, what's the biggest hazard about pulse oximetry? What's the biggest problem? And that's why you're going to go and do the blood gas. What's the biggest problem with pulse oximetry? The biggest problem with pulse oximetry is that you're not always getting accurate results.
For like carbon monoxide and things like that.
Yeah, and so then people will treat the patient according to inaccurate results. Like I just told you, here's an example where the patient is in severe distress, but his SAT's reading 97. So here's an inaccurate. A biggest one too is with your COPDers. We want to maintain a SAT of 88 to 92. I think I told you the story a couple months ago. Oh, maybe a little bit more than that. We have a COPD that's a normal pain in the butt. And the nurse said, oh, that patient's been so, I came on the floor, I'm like, how's Mr. So-and-so today before I even saw the therapist? Oh, that patient's been wonderful all day long, hasn't bothered us. I said, really? Yes, that's been 99 all day long. Well, what did that tell me? When I went down there, he was pretty darn lethargic because they were all happy with his SAT of 99. Well, we knocked out his hypoxic drive. So you get false readings, which give you you treat them falsely, okay?
Mm-hmm.
So watch it, you know, you could have a patient that's totally off their pulse oximeter and it's reading 36 and people are gonna run down there thinking they're not on anything when it's just the fact that the pulse oximeter is off or it's not sticking right, it's not on correctly, they've got all this nail polish on and it's not working, all of those things. So pulse oximetry, remember, has its limitations. It's only so good for so much. So I'm going to ask you about those.
When it comes to retainers, when the CO2 is in the 50s and the PaO2 is in the 50s, that's normal, right?
That's
for
normal.
them, for a retainer.
Yep, and what are you going to give them for oxygen?
Well, you're going to put them on an AEM at the lowest amount.
AEM, absolutely. A lot of people tend to forget the causes of metabolic acidosis and alkalosis, know those. And remember, base excess, if you've got, a base excess is telling you got too much base. So if you've got an alkalotic state, a metabolic alkalotic state, you should have a positive base. If you've got a metabolic acid state, you should have a negative base. So think about what base excess actually does.
Beyond the plus or minus 2,
Yep.
you're saying?
Yep.
Okay, so the normal range is plus or minus 2. But
Mhm.
anything beyond that?
Yep.
Okay.
So if I said to you, you had acute respiratory acidosis,
Mm-hmm.
what would you expect the BE to be?
Higher.
More than the...
In any acute situation,
A
does the
negative.
kidneys have time to change?
No.
No.
No, so it should be normal, okay?
Okay.
The only thing that you should see is instead of the bicarb being 24, it would be 25, but that would be hydrolysis, but it wouldn't be the base excess would still be normal because it doesn't have time to change. The only time you're going to see the base excess changing is when you have compensation or a pure metabolic problem going on. Okay? Good.
Oh, I keep thinking that the base excess is buffer. For some reason, I keep thinking that.
It takes the whole entire page. But what I want you to realize is you got to just look at it and look at, there's going to be a series of blood gases, and what you want to look at is the last blood gas. And you're going to make your changes according to that last blood gas on what you want to do to that patient. Okay? So pay attention. It's going to tell you a little bit about a scenario, because remember we learned that serial blood gases tell us more than just one blood gas. So this is going to help you to decide what you want to do with that patient. Okay? And remember, on our patients, if it's oxygen, you only have 2 answers. Give them oxygen or add them PEEP. If it's a ventilation problem, you can either intubate them, give them by non-invasive ventilation, or if they're already on a ventilator, all you can do is change their rate or change their volume. Okay? Now, when in doubt, if the pH is not too bad, if it's not less than 7.20, you can use BiPAP. If it's less than 7.20, intubate them. Okay? So remember we learned 7.20 is when you really have to react.
You said if it's less than that?
Yep. Anything above that, you can try BiPAP. You know, but anything less than 7.20, we would probably intubate them. Some people might try BiPAP because they really don't want to intubate, but
So
we're
we
gonna go with
see situations like a diabetic ketoacidosis, like those type
Yep.
of blood gases, and we'll
Yep.
have to figure out to put
Yep.
them back.
and no, with diabetic
Oh, you don't
ketoacidosis,
have to.
there you're going to tell me that you expect, what kind of breathing would you expect? Too small in breathing, and that patient's going to need some kind of insulin, is what they're going to need, okay? So there's quite a bit of, again, where I'm going to give you a scenario, and I expect you to figure out what to do with the blood gas. Some of them I ask you what they are, but some of them, again, that CO2 retainer, somebody's going to put them on that non-rebreather, and I will have a minor stroke. You know, now, don't pick the AEM if they're not up. So if I say to you they're in a fire, so read the scenario. So make sure you just watch for that 50-50 club. You know, when you've got that compensated patient that's just a little low on his oxygen, give him an air entrainment mask. You know, remember, chronic patients can get sick. Chronic patients can need oxygen. We're just going to give them a little.
At the lowest level.
At the lowest level. So if I don't give you the choice of an air entrainment mask, you pick the smallest nasal cannula you can. Okay?
Mhm.
Good. Pick oxygen versus PEEP. And I do quite a bit of those. There's probably 15 blood gases where you've got to choose whether you want to give oxygen, PEEP, change the rate, change the volume, put them back on the vent, take them off the vent,
So-
maintain current settings.
So when you're trying to fix the ventilation, that has to do with the respiratory rate and the tidal volume, right? And then when it comes to oxygenation, that's either you give oxygen or PEEP?
Yep.
Like FiO2 or PEEP, right?
Yep.
Beyond the 50 to 60.
Beyond the
add
50
PEEP.
to 60. Or I could, if they're spontaneously breathing, I can give them CPAP. Okay? Remember the difference between PEEP and CPAP? CPAP is for your spontaneously breathing patients. PEEP is for your patients that are on the ventilator. Okay? So PEEP is a mode. CPAP is a mode. PEEP is a setting. Does that make sense?
Yeah.